Good evening, everyone, and welcome back to the April edition of the Indian Journal of Anaesthesia podcast. This happens to be our 40th edition. And to all the first-timers who have joined us, hope you have an informative and engaging experience watching this session. And please log on to Spotify and YouTube where you can catch up with all prior episodes. I'm Dr. Vedhika Shanker, one of the hosts, and on this session, we have with us Dr. Rakesh Garg, the editor-in-chief of the Indian Journal of Anaesthesia, whose reputation precedes him. Thank you, sir, for your valuable time. I also welcome our new podcast host, Dr. Poornima, a senior registrar in the Department of Anaesthesia, Apollo Hospital, Bangalore. Welcome, Poornima. I'm really happy to have you on board and look forward to many an exciting time going forward.
Thank you, Dr. Vedhika.
We thank and invite our authors for this session, Dr. Nidhi Bhatia and Dr. Mridul Dhar. We're very happy to have you with us and thank you for sharing your expertise with all our listeners.
Thank you.
Thank you.
So before we begin, I wanted to ask our esteemed editor-in-chief, Dr. Rakesh sir, a few pertinent questions of the times. Dr. Rakesh, you've taken the IJA from strength to strength. And from an author standpoint, we wanted to ask you a few questions. First of which, the biggest weakness for a lot of anesthesiologists remains to be statistics. Most of us probably know a p-value, maybe a calculation of power of a study. Well, I'm guilty as charged on this front. What is the current demand from a paper in terms of statistics and what is needed for publication?
Absolutely. I think this is important, and those who are following Indian Journal of Anaesthesia, they have seen that, yes, from my side, I'm asking a little more elaborate statistical aspect of your paper. When we talk about the research, when you plan a research, I understand that we are not statistician and we may not be able to do a lot of statistical aspect. So this is one important aspect, that from the beginning, when you are planning your study, do involve somebody who is good at statistics, or make it that somebody from the statistical knowledge, may not be an anesthesiologist, is a part of your team to do it, and try to include it at the time of your planning itself. Second aspect is, when we do a research, we need to understand that what exactly the p-value means. When we say research, there is a basic presumption that we will accept certain extent of error into our study, and something can happen by chance. So that by chance or something error that we accept into a study, I'm saying it very broadly so that it becomes easy to understand. We accept that probably say 5% of error is acceptable to me in my study. And that's why I put it that, yes, let it be, I'll put a p-value of 0.05 as an acceptable statistical significance for me. This becomes important, that it is just giving me a chance or giving me a hint that this error would be acceptable, or otherwise I have to study whole universe to be 100% sure, which is not possible. And this is just the p-value. It does not say that if you have two groups, group is p-value is 0.001, it is highly statistical significance, and group A is much better than group B. It does not say anything. So this is called misinterpretation of the statistical values that we have. Now there are a couple of other things which gives you more broader aspect of its understanding. And that's why IJA nowadays is very particular to ask you for 95% confidence interval to the minimum. When I say why 95% confidence interval, I will put it very grossly once again to understand it. When I do a study, I get some values. If I do it again, I'll get some value. If I do it third time, I'll get some value. Now there is a statistical option wherein I can easily say that I can do this study 100 times. And this is what is called something 95% confidence interval. So if I do this study 100 times, which I am doing it statistically now, not actually. And I say that 95% of time, this will be the mean value, which I have quoted into my study. Every time it will not be the same. If you are traveling from point A to point B, one it will take, say, 67 minutes. Next time it will take 65 minutes. Third time it will say 69 minutes. Every time it will be slightly different. And same will be your study also. So if I do statistically 100 times, what will be those values? So there will be a range. So that's why if those range, 95% of values of that range is labeled as 95% confidence interval. So this is much better rather than to give a single value. And when we say 95% interval, if the values are overlapping in the two groups, even if the p-value may be little significant, it does not have actual significance, even statistically. And that's why it has more information rather than giving one values. Similarly, when we talk of observational studies, we will say that 14% of these patients have incidence of vomiting, 18% has something. This is again very gross because 18% for whom, how much, and then we start thinking of some other things. That's why even for many other studies, we have started thinking of odds ratio, risk ratio, absolute risk reduction. When you talk about complication, adverse effect, this gives a better understanding of the data that you have received. Similarly, if you're doing some interventions wherein you want that this incidence probably will reduce the occurrence of nausea, vomiting, how or which or how many numbers of patients would be reducing this incidence or treating an event by a drug or a technique, how many patients you would need to decrease that particular incidence. And that's why we say number needed to treat. So this means statistical, and these are all basic things. Actually, these are not very sophisticated and hi-fi things. So that's why we need to understand this statistics, and IJA nowadays is particular asking all the authors to get these. And I'm very happy that for last many months and years now, authors are able to accept this requirement of IJA and they are providing us. And on the same side, IJA is also helping all the authors to pinpoint the things that please include these aspects, and we give them a chance because statistics can be done again. I don't give a chance if there is some lacuna in method section, it stands rejected because methods cannot be changed once you have done the study. But statistics can be done, and that's why IJA give chances to all the authors to go back, discuss with statistician, bring out the results again and submit back. And I'm happy that all authors are able to do it. So I think it is as simple as that. And for many months now, IJA is happy to go to the next level of results reporting in the form of statistics. And there's a couple of other things which IJA has improved upon, which is in the table format, which is the representation of data that they mention about. We also need to understand that when to report numbers only, when to report percentages. If the event rates are very small, if the studies are small, 20, 30 patients, no need to mention percentages. Only the numbers needs to be there. If it is more than 100, percentage comes along. So these are some finer nitty-gritties of reporting your results or data, which IJA do stand corrected by the authors, and we give them, we support them, we help them to make these changes in subsequent revisions.
Thank you, sir. The examples you quoted were very simple and were easy to follow. I wish all statistics were that easy to understand, but using that analogy, I think we can apply that to the further studies that we read.
Vedhika, it is absolutely as easy as I have explained you. I think it's not difficult. I'm sure that you will take it along in the next study.
Thank you. So let's get on to having a conversation with our authors. On to you, Poornima.
Hello, everyone. Welcome. Today, I will be introducing our first author, that is Dr. Nidhi Bhatia, professor at the Department of Anesthesia and Intensive Care at Postgraduate Institute of Medical Education and Research. Welcome, ma'am. It is a pleasure to have you on our podcast.
Thank you so much for having me. It's a pleasure.
Today, we will dive into your recent work, which was on the continuous peripheral nerve block in patients with proximal femur fracture. It was a randomized comparison of 3 techniques. So we all know how difficult it is to manage high velocity trauma patients in the post-operative period, especially, and especially when we want to try and reduce the opioid intake in these kind of patients. So diving into it, ma'am, could you tell us what was your primary motivation behind this, and what did you consider as a target when you were starting the study, when you wanted to do this comparison between the nerve blocks that you wanted in this proximal femur fracture patients?
Yeah, so in proximal femur fractures, we know that most commonly when these patients come to us for surgery, many of these patients, these are operated under regional anesthesia. So the epidurals that we give, they are actually a gold standard for managing post-operative pain. But over the years, we've seen that a large number of patients are now being operated under general anesthesia, especially those with polytrauma, in whom at times giving a regional becomes a difficulty or a problem. And worldwide, the incidence of giving general anesthesia in patients with proximal femur fractures has increased to the tune of almost 50 to 51%. So fractures, they come to us following high impact road traffic accidents, and the pain in them is highly intense. So at times managing their pain with just intravenous opioids does not reach the target, and most of these patients are undertreated, especially when we don't have something like an epidural, which we consider to be a gold standard. So we wanted to look at alternatives which we could have in managing postoperative pain in these patients, especially those who are being operated under general anesthesia. So regional blocks are now becoming very handy, and they are being increasingly being used in these patients. So we decided to see how these regional blocks would work in such patients to manage postoperative pains. Now, most commonly we give single shot blocks with adjuvants, but we decided to see how continuous blocks in which we placed catheters for postoperative pain management and how they would behave. So there have been various previous studies in which femoral blocks, single shot, have been given, even facial plane blocks, facial iliaca compartment block have been given, and variable results have been reported. But there has been no study in literature where continuous peripheral nerve blocks have been used in this subset of patients. So hence we decided to compare these three techniques which have been reported in various case reports, but as a single shot, not as a continuous block. So we decided to use a continuous block and see how they would work in this subset of patients.
Okay, ma'am. All right. Moving on, we've seen the prospect guidelines where they talk about femoral nerve block and the fascia iliaca compartment block being the first choice in treating these hip repair fractures or any hip surgeries that they undergo. But you decided to use two approaches in the fascia compartment block, that is the suprainguinal approach and the infrainguinal approach. Could you briefly refresh us the anatomical considerations and what were you targeting when you were approaching two different ways to give the fascia iliaca compartment in comparison to the femoral nerve?
Rightly said, most of the studies are in hip fractures. So patients are coming to us for hemiarthroplasties. Now the pain of hemiarthroplasty is very different from the pain of proximal femur fractures. The proximal femur fractures are more painful as compared to hemiarthroplasties. One. Second, the proximal femur fractures, commonly the subset of patients which we took were young patients who had come to us following road traffic accidents. So proximal femur fractures, you can also see in old patients who fall down, and they commonly have fracture neck femur, which are the fragility fractures. So we didn't take those kind of patients because again, their pain is less as compared to this high impact trauma patients. So one, we took these patients and we knew that the subset of patients which we are taking would have intense pain. So we would want a modality which would address that intense pain in the postoperative period. Hence, we decided to study these three blocks. Now, how these are different, the femoral nerve block, which we used, in the femoral nerve block, it's a nerve block. You are targeting the femoral nerve and the local anesthetic is deposited around that nerve. Vis-a-vis, the fascia iliaca compartment block is a plane block. In this, the local anesthetic is deposited in a plane. So in the fascia iliaca compartment block, we are depositing the local anesthetic in the plane which is present between the fascia iliaca and the underlying iliopsoas muscle. So that is the plane. And through this plane, mainly there are three nerves of the lumbar plexus which are running, which is the femoral nerve, the lateral femoral cutaneous nerve, and the obturator nerve. So by depositing the drug in this plane, we are basically targeting these three nerves. Right. Vis-a-vis, in the femoral nerve block, you're just blocking the femoral nerve. Yes. And the obturator and the lateral femoral cutaneous nerve, they don't actually get blocked because you're just depositing the drug around the femoral nerve. So in the fascia iliaca compartment block, we are depositing the drug in this plane with the intent of targeting these three nerves which run in this plane. Hitting the plane below the inguinal ligament And in the suprainguinal, we are targeting the plane above the inguinal ligament. So you are depositing the drug more proximally above the inguinal ligament. So the majority of the drug, because you are depositing it more proximally, it remains within the pelvis. And it is said that the suprainguinal fascial iliaca compartment block results in a better spread of the drug towards the obturator nerve medially. While in the infrainguinal fascial iliaca compartment block, the medial spread of the drug is kind of blocked is limited because of the iliopectineal fascia. So there have been numerous studies, cadaveric studies, to see the spread of the drug in these two compartments. So when these cadaveric studies were done and the MRI was done to see the spread of the drug, it was found that with the suprainguinal fascial iliaca compartment block, there was a better spread of the drug to all the three nerves. That is the obturator, the lateral femoral cutaneous, and the femoral nerve. Whereas with the infrainguinal compartment, there was the spread medially towards the obturator nerve was less as compared to the suprainguinal. So that is why we decided that we'll compare the three techniques.
Thank you, ma'am. Moving on, in your study, when you gave the initial bolus dose with ropivacaine, you used a weight-based strategy. In general, we are commonly we use this blanket volumes of 25, 35, maybe 40 ml, although limiting within the toxic dosage. How did you decide you wanted to use a weight-based strategy when you wanted to give this bolus dose? And also, what was the rationale when you wanted to fix a dose at 10 ml per hour for a 24-hour post-operative infusion?
Yeah. So all of this was based on the previous literature. So commonly when we are giving plain blocks, generally we give a bolus of 20 mLs or 30 mLs. And in fascial iliaca compartment block, you can go up to 40 ml also. But then the patients that come to us in our trauma center are varied with different body habitus. So I don't think you can equate the drug dose in a 50 kg man with a 100 kg. I feel whatever drugs you're giving, they should be weight-based. We went through the literature, and there was this recent literature where we came across where they have used this dosing in the plain blocks based on the body weight. So hence we decided to use that rather than just giving a blanket 30 ml or a 20 ml. So depending upon the weight of the patient, we decided our dosages. And similarly, the continuous infusion of 10 ml per hour that we gave for the initial 24 hours was all based on previous literature. So there have been reports where people have also used in various other studies, patient-controlled pumps have been used. But since we didn't have them at that time, so we decided to do a continuous infusion, and our doses were based on the literature which was existing.
Why did you prefer to put a catheter? I mean, do you normally do this in your routine practice to all trauma patients, or was it only because of the study in comparison that you wanted to do? And also in your study, you're removing the catheter after 24 hours. What was your main intention when you decided you wanted to place catheter for these patients?
Pain following this high intense trauma, the fracture pain is one quite intense, and then it is very dynamic in nature. To address this, the intense pain and the dynamic nature of pain, you need to continuously manage it. You cannot say that, okay, now I'll give a bolus, then I'll see my patient after 8 hours, give another bolus, because the pain is so dynamic in nature. So we decided to put in a catheter so that we could continuously provide analgesia to our patients. And the other problem which we see with boluses that we give of whatever drugs we're using, or just giving a single shot block, is there is a high incidence of breakthrough pain. So we wanted to avoid that also. So we wanted to continuously provide pain management to our patients, because the pain is in these cases highly intense and highly dynamic in nature. So that is why we decided to go in for the catheters, which we placed just before the surgery got over. The catheters were being managed in the postoperative period. Now, coming to the second part of your question, we routinely put catheters to our patients. We are also doing it for the upper limb surgeries. And not only in the post-operative period, we also do it pre-operatively. As soon as the patients come, we are doing on-arrival blocks. So as soon as the patients come to us in the trauma triage, so we receive a call in whom they feel that pain management is needed. And at times we do put in catheters, be it for the upper limb or for the lower limb. So how does it help is when you're placing the catheters, like you can use it in the trauma triage, because the pain relief is there because of the catheters. And these patients, even in the preoperative period, when they are in the emergency, they are routinely being shifted for either radiology, then their dressings
Yes.
are being done in the emergency, the examination is being done by the surgeons in the emergency, which is all of this is very painful. Even if the patient has to be shifted, it is very painful. So the catheters really help us in that forte, because the catheters are in place and you could give a continuous infusion. So the patients are totally pain-free. The examination of the wound or the fracture also becomes easier because the patient is pain-free and the dressings become easy. And when the catheter is in place, if the patients are shifted to us for surgery, we use those catheters only to give an anesthetic dose of local anesthetic. So it saves your OT time. We are being routinely using it in the entire perioperative period, be it pre-op, intra-op, or post-op.
All right. Slightly to deviate, do you have an experience having your catheters pre-op and the ones post-procedure? Have you found any difference in which group of patients had a better outcome in terms of pain?
Doing it pre-operatively definitely provides greater benefit, because by the time the patient is there, you have taken care of, given what we call as preemptive analgesia, given analgesia to the patient before the surgical intervention. So definitely in that subset of patients, the outcome is better. We also did a study recently where we used the same catheter in upper limb surgeries, where we placed them pre-operative. What we found was that the patients they were very comfortable even in the preoperative period, be it for the dressings or for any radiology. And then increased the OT time, the post-op recovery was better, and the discharge time was also sooner. So their hospital stay also reduced significantly. If you follow up such patients, the incidence of chronic pain is also less because you're preemptively, taking care of the pain.
Pain, true. True, ma'am. Coming back to it, out of the 3 blocks that you performed, that is the suprainguinal approach, the infrainguinal approach, and the femoral nerve, do you have any preference or do you have any statistics which you experienced in terms of how you were able to perform the blocks which were easier in terms of skill or the time that it took, or any chances of failure in which kind of a block while either performing the block or placing the catheter? How would you differentiate between these 3?
So all of these 3 blocks are they're very simple blocks to perform. So in our study also, we saw the time to performing the blocks and there was no difference between the 3 groups. So all of them, majority of the patients, we were able to perform the block within less than 10 minutes. So 3 are very simple blocks. Say my favorite is the suprainguinal fascial. One, for the reason that the analgesia provided is very good. And second is the fixation is good. We normally tunnel our catheters so that they remain fixed. Yeah, so tunneling helps. Now, when you go infrainguinal, because at times of the movement of the leg and in the infrainguinal region, the catheters, they tend to get dislodged. But in our case, what saved us was we did not find any incidence of dislodgement of catheters. One, we used tunneling in some of the patients. Second is we used an in-plane technique of inserting the catheter. When you're inserting the catheter in plane, it gives a long route to the catheter. It is in place. So because we used an in-plane technique, most of the catheters, they stayed in place. And secondly, we used it for the initial 24 hours. During this time, the pain is intense. So we decided to, because it was the first time we were doing it in proximal femur fracture, so we wanted to see the feasibility of it. So the catheters, they remained in place in the initial 24 hours. The dislodgement was not there. One, because of the in-plane technique we used, and secondly, because during the first 24 hours, the patients were immobile. They were not moving. Yeah. So then again, the dislodgement was not there. So that helped. So per se, we did not notice any complications. So we did keep it for just 24 hours, which we have reported as limitation of our study, because it was for these initial 24 hours that the patients were with us in the post-anesthesia care unit. Following that, the patients, because it's, heavy footfall is there of trauma patients in our center. So we could not keep the patients for longer duration and they had to be shifted to triage. So we decided to remove the catheters, because then following them up in the triage was a task because of, constraint of staff. So that is why we wanted to see how best it works in the time frame when the pain we feel is the most intense, that is the initial.
All right. It has been very insightful from your end to know about this, especially placing these catheters, different approaches. We are very used to giving single shots. So I think catheter approach is something that we would want to try in the near future after talking to you. To end with this, do you have any clinical implications that you want to address now? And also, is there any future scope to research in this field, something else that someone can take points from and then go ahead and research and make it more better or get more info on this? What would you like to say, Dr. Nidhi?
Yeah, so with the catheters, actually, it's, I think, the way forward rather than just giving single shot wherever possible. I think we should go ahead and place catheters. So they make your life very easy as far as pain management is concerned. That is what I feel. So especially when you do it in the perioperative period rather than just putting it in the postoperative, especially when you talk about trauma patients. So
Yes.
putting these catheters on arrival as soon as the patients come in trauma triage, that is the time when the pain is of the highest intensity,
Highest. True.
following high impact trauma. So if at that time you are able to manage their pain effectively, so the catheters come in very handy. Like I said, you can just keep the catheters till the patient comes to you in the OT and continue it in the postoperative period. So in certain set of patients, we've also kept them for around 3 to 4 days.
Okay.
So yeah, so they become very useful. Like in our country, it's not a norm, but outside, when you look at the Western world, people have sent patients home with catheters in situ so that their pain is managed. And after 1 week, they are called back and then the catheters are removed. But as of now, it's not a possibility because the educational level and the patients is different as compared to the Western world. So it's a way forward using continuous peripheral nerve block catheters. For future studies, we can use these catheters like we used it just for 24 hours. You can use it for longer duration. In addition, instead of just giving continuous infusion, you can use patient-controlled analgesic pumps, which are again more useful. They would be beneficial rather than just giving a continuous infusion, because then the patient would give a local anesthetic depending upon the pain that the patient is feeling. Future studies can be done using PCA pumps and for longer duration, and maybe multicentric trials because every center has a different subset of patients.
True.
Yeah.
Yes. Thank you, Dr. Nidhi Bhatia. It was very insightful, and especially you giving away the last few tips on what we can do in a future scope on this topic. Thank you so much. We're very glad that you could join us. We're looking
Thank you.
forward that you could join us many more times in the future. And
you
over
so
to you, Dr. Vedhika. Thank you, Dr. Nidhi.
Thank you.
Thank you so much, Dr. Nidhi. So we now take a move from regional anesthesia to pediatric anesthesia. I would like to welcome to the IJA podcast, Dr. Mridul Dhar. He is an associate professor in the Department of Anesthesia at the All India Institute of Medical Sciences, Rishikesh, India. Thank you for joining us today, sir.
Thank you, Dr. Vedhika, for the invite. Dr. Rakesh Garg, sir, for the opportunity. Looking forward for the discussion.
So a brief bit about your article. It's looking into the satisfaction or how the outcomes were with pediatric patients who received early postoperative oral hydration versus those who received the more conventional delayed one. So beginning with, what's inspired you to investigate early postoperative hydration, and how does this align with the evolving trends of enhanced recovery protocols? In the current Indian scenario, how necessary do you believe it is to try and promote ERAS, if you think it should be promoted in our scenario?
So, as you said correctly, IRAS is the way forward. For the past so many years, there's been a lot of data and literature on adult IRAS protocols for various types of surgeries. And of course, in Western literature, there are pediatric IRAS protocols as well. But in India, there is a definitive lack of literature and even practice of implementing these IRAS protocols or even the components of IRAS in pediatric surgery. So
Yes.
that is one thing which initiated, and of course we are looking at one part of the ERAS pathway. There are many different ERAS pathways, starting from the pre-op to the intra-op to the post-op. For example, just to give a brief outline, let's say in the pre-operatively you want to decrease the starvation period, you want to give preemptive analgesia. Intraoperatively, you want to have a guided fluid therapy. You want to use minimally invasive or less invasive surgical techniques. We want to use regional anesthesia techniques as much as possible, less opioids, and and post-operatively have a good post-op regional anesthesia if possible, and have minimal catheters. So these are just the pathway we are including. We're looking at one aspect of it, which is the decreasing the starvation part of it. And even though there are guidelines and there's enough literature, we want to decrease the pre or post-op fasting periods, but still practically what we observed, at least in our setup, is that the patients have a prolonged pre-op fasting period, maybe let's say 12 since 12 in the night, and post-operatively it's like 4 hours, 6 hours often, because there is a little bit of apprehension regarding pediatric patients the safety of initiating oral feeds early. So surgeons, nursing personnel tend to err to the side of safety, which they think is safety. So this is one thing which we just wanted to get some literature, local data, and which will help us in the future to try to implement it into our local policy.
Absolutely. So what, especially when it comes to pediatric patients, I think the fear scale just shifts entirely. Everyone's a little more cautious, and it's okay if the child cries a little, it's fine. We know a crying child
Yes.
is an awake and,
True.
is a safe child. Thank you for that point. With this study, I'm sure your exclusion criteria had to have been absolutely on the mark. So how did you go about this?
So, of course, safety was again a priority especially when you're doing academic research. So, and this was an RCT, so of course you have to be extra cautious. So, we chose a population which is generally representative of most of the pediatric surgeries, but of course we had to exclude certain types of surgeries where the child may be vulnerable in the post-operative period. For example, any kind of oropharyngeal surgeries, neck surgeries, neurosurgeries. Some children who had upper respiratory tract infection, more chances of perioperative respiratory adverse events. We were trying to avoid those patients as well. Those with some swallowing problems, dysphagia, some mental altered issues, all these children which maybe have a little higher risk of having complications with early feeding. So these kind of children were excluded from the study.
Thank you, sir. Thank you for explaining that. And the element of safety, even outside, especially when you're trying to bring in a new protocol into practice, is very key. And I think the most interesting part of your study, at least personally, was how you utilized the FLAC score as a surrogate for patient satisfaction in preverbal children, whereas most of us are very familiar with using it for pain. So how did you choose this scale and why? And how did you think that it would correlate with capturing this hydration-related discomfort rather than, what we're used to, which is pain management?
So I would add it is a little controversial also in a way. That is the core aspect of this article, using FLAC score as a surrogate for patient satisfaction in a way. So of course we know that FLAC score is a behavioral score, and traditionally, conventionally, we've been using it for measure pain. But we also know that older children, adults, they can explicitly say that I have pain. But let's say the children age group we are looking at, this around 1 to 5 pre-verbal preschool children. So they may or may not be able to explicitly tell that they are having pain. So they will just be in some kind of a discomfort. They might be cranky. I'm sure we can attribute some part of it to the pain as well. But our proposition is that it's just general discomfort, which could be because of pain. It could be because of thirst, hunger, or just general anxiety. So in this, we are looking at using the FLAC score as a surrogate for patient satisfaction. So there were a few similar studies in older children, a few Chinese studies, in which they were again looking at early hydration, and they were looking at the thirst scores or incidence of thirst in the older children who could tell about those scores. So of course, younger children 1 to 5 will not perhaps be able to explain that. So we're using some behavioral score, in this case the FLAC score, with the assumption that in our study we have standardized all the perioperative techniques for regional anesthesia, perioperative pain management. In the end, as we can see in the results as well, the baseline point scores were similar. So we have standardized and removed pain as a confounding factor, and the difference which we observed finally, we can attribute it to the non-pain factors like hunger, thirst, anxiety, etc. And we also proposing that the hydration or just the act of oral feeding will decrease the anxiety as well, also decrease the perception of pain as well. So it's looking at a more physiological, wholesome approach rather than just saying that FLAC can only look at pain.
So in the early hydration group, if a child is crying and has a FLAC more than 4, how would you approach it?
So traditionally, as you said, if the FLAC is more than 4, you would start with some kind of a rescue medication. And previous studies on this, even when they are giving some studies which have done on early hydration, they have also targeted a FLAC score of 4 to do any kind of intervention. So what we are proposing is that perhaps we are over medicating rescue analgesia for these kind of children. So our first attempt can be to give them oral hydration, and maybe that will decrease the post-operative opioid or rescue analgesia requirement as well. So one more thing I would like to add is that FLAC score here in the study might not be a direct marker of hydration status, because we are giving a standardized hydration protocol for everybody. They might not be dehydrated, but just the physical act of oral intake, we can make it more physiological. Just the act of returning to normalcy might have an influence on the parents as well, and especially the child will feel more comfortable. Just try to look at it in that way.
So you're measuring comfort. That's very interesting. So your study was a single-blinded study, which in a busy postoperative care unit, I can imagine that was difficult. How did you ensure the blinding happened and that you could eliminate bias while recording the flag scores? Who recorded? Who was blinded? Could you go over that a little bit for us?
So yes, you are correct. In these kind of studies, blinding is challenging because, of course, most of the people in the PSU in the intraoperative period, they would know the intervention, but we wanted at least the outcome assessor to be blinded. And that was kind of feasible for at least the primary outcome, which was the flag score at 1 hour in the PSU. Let's say I know the allocation is opened much later in the postoperative period, so intraoperative all measurements does not have an issue that can be taken by the outcome assessor. The allocation is concealed, is opened at the time of PSU, so the PSU staff know the intervention. Let's say I am involved in the process of helping out and giving the intervention, so I know the allocation. But let's say I have a resident in another OT or somebody else who I have told that you have to take flag score measurements at this point as baseline at arrival in PSU, and then you can come and back after 1 hour and take the parameters again. So they will have no knowledge of the intervention given. So one group is like a standard care, nothing is happening. You give rescue analgesia if required, but another one will include the intervention, which is giving early hydration within half an hour of arrival. So we were able to blind the outcome assessor for this purpose. Again, parent blinding was not feasible because they were involved in giving the intervention. So that comes with a little bit of a caveat, especially when we are talking about their satisfaction scores. But for the primary outcome, which is an objective flag score, that I think we successfully blinded it for the outcome assessor.
Thank you for sharing that with us. Parental satisfaction was notably higher in the early hydration group. Do you think that parental perception of care plays a role in how pediatric patients recover? And more importantly, should we begin factoring this into our postoperative protocols?
Definitely. This is again a very interesting aspect of the study we want to look at, because most of the times the anxiety or the apprehension of the parents does reflect to the child as well. It could be in the preoperative period as well or in the postoperative period. So keeping the parents happy is also one aspect of the overall perioperative care of the whole family. When the child is coming, he's coming with the whole set of parents and the whole family setup. So if you're looking at again as a wholesome approach and we're trying to make them also happy and their perception of the care given to their child. So I think that is what we saw in the scores here. Again, it comes with a little bit of bias because they knew they were part of the intervention group, but I still think there is some result to bring out of this, because when they see their child is being given an oral feed, this is something like a act which is bringing them closer to from the unknown of anesthesia and surgery to the knownness of feeding the child. The child will be happy, the parents will be happy, there'll be less anxiety generally. The parents might be more compliant to your medical advice, general better perception of the healthcare system and the care given. I think these are all important aspects which we should consider when we're taking care of these children.
Absolutely. So I think, especially with our Indian culture, we really take feeding and the child's comfort extremely seriously. So having that involved with anesthesia also makes the entire medical care a little easier, and their cooperation obviously helps.
Like to add one more thing, this is a practical or a personal experience. When there is a young children involved in child involved in anesthesia, it comes out to the post-op PACU, more at least 50% of the mothers I see, they're crying because this is a young child is coming and he's suffered something which is something perhaps not required. So making them happy is also going to hopefully reflect on the child as well.
And very honestly, it'll make our jobs and
Yes.
situation easier handling things in the PACU for sure. Coming back to parents, how did you address consenting parents for this study? Because when you talk about the very small chance, but very scary sounding adverse events like aspiration, nausea, respiratory distress, these are all quite alarming. How did you talk to the parents about this whilst consenting?
Again, it's a very tricky way of doing a tricky aspect of this whole situation. Whenever doing any kind of academic research, as investigators, our purpose is to somehow convince the parents to be part of the study, but it is also our responsibility to explain to them all the possible options. Obviously, we're going to sell our intervention to them, and most in our study, out of perhaps 75 who we approached for them, only 4 of them, I think, they refused to be part of the study. I observed in our study, most of the parents were willing, because this was something which was not very scary, like an intervention or a block or some special kind of a technique. It is just something which we wanted to bring the patient close to normal. So most of them were on board with it. But again, we should not be overzealous, and we should explain to them that this is an investigation. You could either end up in a no intervention group or the intervention group, and there are some risks which are involved. But tell them that all these things, we have protocols in place, we can manage them, and if there's any issues, everything is going to be taken care of. So those aspects of doing a trial should also be considered while trying to be as convincing as possible.
Absolutely. So now that you've done this study, how would you go about a rollout of this early hydration protocol? Would we have a chart? How would it look? How would you educate the PACU staff? And most importantly, how would you flag the red alert patients or the signs to look out for once initiating this early hydration protocol?
Research was just to add some literature. It's a small study, but this is the purpose is to add some local literature based on which we can implement, as you said, some local protocols in which we can try to include early hydration in initially perhaps in suitable surgeries, safer surgeries, and then we can include it and move on to other surgeries. Because in this study, we have a major portion of ERAS protocol, ERAS pathway studies are in pediatric cardiac surgery, gastrointestinal surgeries, which we have kind of excluded just for the purpose of the research. But finally, we need to get into those types of surgeries as well. So we can start small. First thing, of course, is to have a little bit of a protocol and guideline in place in which we can choose what are the suitable candidates to go for early hydration. What is the volume? What is the type of fluid given? What is the timing of fluid? For example, in this study, we said that within half an hour of PSU arrival, as long as they're properly awake, the PSU discharge criteria, they're all okay, reflexes are fine. So all those guidelines about when to, timing wise, we have to keep in place. Which type of patients, of course, certain type of patients initially we can include. Once all these protocols are placed, we can perhaps start sensitizing in the next stage. So we can do this in a stepwise manner. We don't need to bombard and say you have to do this from tomorrow onwards in the PSU nursing personnel. So we can start with having the theoretical documents in place. Next, we sensitize the PSU staff by maybe having some simulation exercises about what are the warning signals which child to select for this early hydration. What are the warning signals? Let's say somebody is having gagging or choking, when should to stop by early hydration. Proper monitoring of all these patients, management of hypoxia, aspiration, what to do, initial management. All these things can be done by small mini simulation exercises. In situ simulation is something which we can do rather than taking the nursing personnel to a simulation lab. Just have small in situ simulation exercises, which is much more feasible and much more effective. And then next go on to including parents in the process as well. We can have some pamphlets, we can have some literature in which they feel involved in the care of the child as well. For example, we allowed the parent to give the intervention to the child. So we had said that the child should be given the fluid or the dextrose water in a container which he has at home with the hands of the parents. So that made it more successful, because other previous studies we saw that around maybe 30% of the children refuse early hydration when they were given. So here our intent was to make it as conducive an environment as possible, so that the child does not refuse. In the intervention group in our study, around 3 out of 30, around 9 to 10% of them refuse the early hydration. So again, that is one thing in which you can involve the parents. They feel part of the process. They become more knowledgeable about it. They tell other parents, other patients about this as well. And finally, take some feedback from the staff, from the surgeons, about their experience, so that we can again generate more data, have a data-driven approach, and then finally include these protocols in more and more types of pediatric surgery as well.
Thank you. And as you rightfully mentioned, the surgeon plays a massive role in your NBM orders, pre-op as well as post-op. You may write, but at the end of the day,
It
the
doesn't have.
orders that are followed by the nursing staff are
Is the
going to be a
surgeon's one.
surgeon orders.
Yes.
Yes. So having them on board, having their buy-in is vital. So this is very useful information. Thank you for going over the study, for talking about the controversies. And I think this was very beautifully conducted, and hopefully we can see more studies coming out with utilizing behavioral scores for not just pain, but overall assessing patient comfort.
Thank you so much.
Thank you, Dr. Nidhi. Thank you, Dr. Mridul, for being a part of the IJA podcast. It was invaluable to have your insights and your personal viewpoints that, we cannot see in an article.
Thank you so much. Thank you for having us.
And as always, as we like to say at the Indian Journal of Anaesthesia, stay curious.